Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Rachel Yates. She is a nurse and healthcare executive. Today's Kevin MD article is Patients Pay When Medicare Care Coordination Codes Go Unused. Rachel, welcome to the show.
Yes, thank you so much for having me, Kevin.
So let's start by briefly sharing your story, then we'll jump right into your Kevin MD article.
Okay, great. Yes, so I'm a registered nurse. I have almost 10 years of experience. I did start healthcare when I was fairly young. In high school, I got my nursing assistant license and my EMT through the vocation programs that were offered. When I graduated, I went straight into college and got my BSN, where I started my nursing career. And it was a trauma surgical ICU. And then I spent a lot of my time in virtual nursing remotely. I am finishing up my MSN in executive nurse leadership right now, and I do plan to start my DNP this fall. I believe that you don't have to wait until you have every credential behind you to actually start building something. So, me and my husband, Savante, we founded Premier Care Coordination. It's a nurse-led coordination service, specifically the program's community health integration and principal illness navigation that we offer to practices.
All right. So you wrote this article on Kevin MD. Patients pay when Medicare care coordination codes go unused. Tell us why you decided to write this article and then about the article itself for those who didn't get a chance to read it yet.
Yes, so in 2024, CMS actually introduced two new categories of reimbursement called Community Health Integration and Principal Illness Navigation. So these are funded for exactly the kind of patients that would have kept a lot of my ICU patients out of the hospital in the first place. These are reimbursable services that any practice can deliver today for the patients that they are already seeing. But 2 years later, most practices still aren't utilizing them. I wrote this piece because I think this is one of the most underdiscussed topics in healthcare right now. Practices have the patients, the funding is there, and the clinical work that would help them is well understood. What's missing is the operational layer that ties it all together. And the thing I really wanted the physicians to hear is they don't have to build that layer themselves. They don't have to hire a whole new team. They don't have to take their existing staff and pile this on top of everything else they're already doing, and they don't have to redesign their workflow. This work can be done by contracted auxiliary personnel under the physician's supervision, which is how these codes were designed to be delivered. So a company like ours, Premier Care Coordination, we come in and operate at that layer. So the practices get the clinical benefit and the reimbursement without that extra burden on their team. And for my piece here, I really wanted to make sure that to let facilities know that this isn't just a billing thing, it's actually a real part of clinical care.
Mhm.
The longer we keep treating coordination like it's optional, the more patients end up paying for a problem that was never theirs to begin with.
So give us an example of a common patient or a common scenario where a physician would use these codes.
Okay, so there are care coordination companies out there that essentially do documentation. They log the calls, they check the boxes, they generate the report at the end of the month. And what I'm building here at Premier Care Coordination is different. So every patient on our service has a named nurse responsible for them. They're not in a rotating queue. So when something comes up between visits, for example, a blood pressure trending the wrong way, it could be a missed medication refill, a new social barrier. That nurse is the one actioning it in real time.
Mhm.
They're not documenting it for someone to review later. By the time the provider sees that patient at their next visit, the issue is already worked. It's not just charted. So documentation is only useful if there's a clinician accountable for acting on that data. And this is what closing the gap really means. We have to continue care between visits. We can't keep expecting a 15-minute appointment to fix everything.
Now, what are some of the reasons why these codes are so underused? Why are physicians overlooking these codes?
I believe the issue here is education.
Mhm.
These codes are fairly new. They were released in 2024. And when I do speak to practices, a lot of them say we already do CCM. So I have to explain to them that these are expansions from that CCM that are offered to your patients that you already see.
And in terms of outcomes, as far as you know, is there any data or studies that show that coordination in between hospital visits eventually reduce these patients from going back to the hospital for readmissions?
Since these codes are fairly new, there's not much quite there's not much data on the new codes, but there is substantial evidence going back over a decade showing that care coordination reduces readmissions and improves outcomes for chronically ill patients. So CMS wouldn't have built these reimbursement structures if the evidence wasn't strong. The challenge has been whether it works. The challenge hasn't been whether it works, it's been how to deliver it consistently at scale.
So give us some stories or case studies of either yourself or other nurses in between going to these physician visits or in between hospitalizations. What's a typical care coordination visit or interaction like?
So for Premier Care Coordination, we really want to be an extension from whatever facility we work with. So we introduce ourselves as an extension from that practice and let the
Mhm.
patient know that we're calling from this specific doctor. And throughout the month, we follow up with the patient, making sure that they get all of the social needs that they need. Those are met. The line that we have is open. So we're not just making sure they get those 60 minutes for the month. They can
Mhm.
call whenever they need to. If there's an emergency or if they forget something, we are here for them. We do go over those 60 minutes if needed. It's just not specifically set for those 60 minutes. We really want to provide that premier care for those patients.
And then this coordination is primarily done virtually or over the phone. What if someone needs to go to see the patient, do a house call, for instance, in between visits?
Yes, so if a patient needs to be seen in between visits, so what we do, we have full access to the provider's office. So if
Mhm.
they need to come in to be seen, we can coordinate that and schedule them an appointment. We do work with some home health agencies. So if a nurse or a nurse practitioner is available, that nurse practitioner can see the patient, or we coordinate a way for that patient to get the care that they need, depending on the situation.
So can you tell us a story of something that you or your team has caught from a care coordination standpoint that may have prevented that patient from a readmission or that patient from medically deteriorating? What would be an example of something you guys caught?
Yes, an easy one that I remember is medication. There's a new medication, a patient had a new medication that was prescribed. I had a phone call that the patient wasn't sure how to take it. I explained to them, or I had them read what was on the bottle, and the patient couldn't understand the medical wording on how many times a day the medication needed to be taken. So I explained it to the patient, and instead of that patient not taking that medication and causing more health issues that prevented a readmission or something deteriorating that patient's health, by me being able to explain and take the time to really educate that patient on how to properly take that medication that that provider prescribed for that patient.
So I know that you have a service where you, of course, you provide care coordination. So what's the landscape like today? Do most hospital systems and physician practices, do they do their own care coordination? And if so, how much work goes into that versus contracting out to a company like yourself?
Yes. So right now, if they're doing care coordination in-house, that is a lot of burden on the staff that's already existing. And if they were to add DHI or PIN into their existing staff, it really wouldn't be possible because of how much documentation is needed. The time requirements with those patients is more than what CCM offers. So
Mhm.
the CCM is about 20 minutes that they need for the month. The CHI and PIN, you need to have a 60 minutes in order for that patient to qualify. So the hospital and staff would not be capable of keeping up with the patients and giving that quality care that is needed.
So in general, however much Medicare reimburses for chronic care coordination, is it still a net positive financially for these practices to reimburse for this code because they still have to pay for contracted services like yourself, right?
Yes, so the way it would work is they get the reimbursement, and if they were to work with a contracted auxiliary personnel like our own company, we have certain ways we work with different facilities, but basically we do a fair market value where they keep a portion of it because they have the patient panel, and then they would pay the contracted auxiliary personnel.
So tell us in terms of what you see in the future or future trends that you see as a result to chronic care coordination. What do you see on the horizon?
Yes, so care coordination is one of the areas Medicare has consistently invested in,
Hmm.
even when other reimbursements have been cut. The 2024 expansion of CHI and PIN, the 2026 expansion to the mental health counselors as well. These are growth signals, not cut signals. The trend is towards paying for outcomes, and that's exactly what these codes are designed for.
We're talking to Rachel Yates. She's a nurse and healthcare executive. Today's Kevin MD article is Patients Pay When Medicare Care Coordination Codes Go Unused. Rachel, let's end with some of your take-home messages that you want to leave with the Kevin MD audience.
So if there's one thing I wanted to leave with the audience would be that Medicare has built a real opportunity that most practices are missing right now. It's not because anyone is doing anything wrong. It's because the system to actually capture it hasn't been built into how practices run today. The patients who qualify for CHI and PIN are patients you already see every single day. They're the chronically ill ones, the ones with social complexity, the ones who keep up ending up in the ED for things that probably could have been prevented if somebody had been checking on them between visits. Medicare actually wants to pay you to keep those patients well, and that's what these codes were built for. And the patients you're missing this for are the ones who need it the most. The
Mm.
patients with dementia whose daughter is trying to figure out a brand new diagnosis on her own, the patient with COPD who keeps ending up back in the hospital because nobody's catching things early enough. And you don't have to build this on your own. You don't have to figure it out from scratch either, but you do have to know that these new codes and programs exist, and you do have to decide to do something about it, whether that's building it internally or partnering with a company like ours that's already built. Either way, your patients have been waiting on this longer than they should have to.
Rachel, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Thank you so much for having me, Kevin. It was a real honor.